Bisa saya bicara dalam bahasa Inggris ya, dia.
Baik, baik. Boleh Pak, boleh, boleh, boleh.
Oke. Oke.
Mungkin pertama saya izinkan dulu untuk membuka kali Pak.
Baik. Oke, boleh,
Ah,
boleh.
ya. Baik Pak, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and welcome everyone. Ladies and gentlemen, dear professor, respected lecturers, fellow student, and other participant. Welcome to Professor Insight Volume 19, organized by the Master of the Information System Program, Telkom University. My name is Egi Alfansa, and I'll be your moderator for today's session. Honorable to the Rector and the Dean, Honorable to the Head of the Master of Information System Study Program, Associate Professor Rahman Lubis, BIT, MIT, MM, PhD, IT. Honorable to the speaker in this afternoon, Professor Dr. Abdul Wahab Abdul Rahman, B.Sc, M.SEE, Ph.D.
Udah bilang makasih.
Uh, okay, ladies and gentlemen, Professor Insa, the discuss forum that they follow to learn directly from explore and the professor about important and current topic in technology. Today, we will discuss a very important topic, mental health technology. This topic is very relevant today because technology is the increasingly used to the support mental health care, such as early detection, monitoring, and digital therapy. It is great to the honorable for the welcome the our speaker, Professor Dr. Uh, Abdul Wahab Abdul Rahman, B.Sc, M.SEE, Ph.D. From the International Islamic University Malaysia. Professor Dr. Abdul Wahab Abdul Rahman is the senior professor at the International Islamic University Malaysia. He has the extensive experience in the information technology and the system engineering, research and academic publication. They use technology to support human well-being, especially in the mental health. He has been actively involved in the academic research and international discuss related to technology-based mental health system. Uh, with a future delay, let's welcome Professor Dr. Abdul Wahab Abdul Rahman to the present in the talk entitled Mental Health Technology. Professor, the time is the screen are yours.
Thank you, Agi. Okay, what I will do this evening is I will talk about mental health and EEG analytics. I think a lot of us has been using AI and so forth, but AI specifically, if you want to use AI in any of your analytics, you have to really understand what you want to analyze and what is it that you want to use it for. Like here, I will focus on mental health, especially in using the EEG signals to analyze the brain. And analyzing the brain patterns requires the understanding and knowledge in this particular case of how the brain actually works. So I will try and give you some idea, basic idea, as far as what the brain and how the brain works, and then what is EEG and what is also QEEG, and then see how we can make use of all these signals to analyze our brain for the purpose of mental health. Okay, I will start. Okay, I want to talk about the executive summary, but I will introduce what is this QEEG and also EEG signals. And I will also introduce what we have here in UIA or IIUM as far as neurofeedback and what we have done. And also how we actually use the brain waves to have an early detection of children with autistic, okay, and Asperger syndrome. At the same time, how we use emotion to analyze motor movements and so forth. Okay, so these are the things that I will try and do within this 1.5 hour period. If we have time, I will extend to the idea of how we try to detect porn addiction using falsification. Okay, this is also another new area, not just using or analyzing using AI, but also using fuzzy logic. okay, and how we actually do it. So a more complex AI understanding of the feature extraction. Okay, if I have time, I will go through that. Okay, we'll see how. Okay, QAG. I will introduce to you as far as the brain is concerned. You know that the brain, we actually subdivide it into four different areas. We have the frontal lobe that is right in front here. And then we have the parietal lobe, which is right in the center. And of course, the occipital. And on the side here, we have the temporal lobe. They have their own function. For example, like if you talk about the occipital lobe, this is where you do all the visual processing. From the eyes, it goes right behind us as far as the occipital lobe. And most of the processing is done right at the end there. Okay. And then, of course, the temporal lobe is where you talk about all the audio, your voice, your sound system, and so forth, you know. So this is where you have the auditory system, auditory information. Okay, and to understand spoken language, okay, you actually make use of the temporal lobe area. Movement. For example, if somebody have got vertigo, vertigo is a sickness where when you have movement problem, okay, you will feel very, very giddy. So therefore, in this case here, it involves the temporal area. And that is where the liquid from the ear, just above the ear, is where it causes those problems. Face recognition, although it has nothing to do with visual, but face recognition is also done by the temporal lobe area. Okay. The other one is the parietal, which is right in the center here. Okay, that's where your primary sensory cortex, touch, body position, counting, front, and so forth is done by that particular area. And the frontal lobe is the primary motor cortex. In other words, all the fine motor movements, instead of looking at the cerebellum for the fine motor movement, you also have the prefrontal lobe looking at all the motor movements, okay? And then, of course, the prefrontal is right in front there. Okay, that is a working memory. And that becomes very, very important and critical, especially when you talk about executive function. Okay, and also emotion. Okay? So that's basically give you some idea as far as the brain is concerned. That is why don't try to get somebody to knock your forehead, okay? Because knocking your forehead may affect your prefrontal cortex. And that may actually affect as far as your executive function and so forth. If you're riding a motorbike, make sure you put on your helmet, because if you don't, when you have an accident, any part of the brain, if shake, that may cause a lot of damage to your brain itself. And you may have what we call PTSD, post-traumatic syndrome disorder. Okay, so therefore, in this particular case, try to avoid. Other than the EEG, we also have fMRI, which is the functional magnetic resonance imaging system. Okay, we have the PET, which is the positron emission tomography. And we have the SPECT, which is a single photon emission computer tomography. And we also have the NIR, or the near infrared spectroscopy. Okay, all these are very useful, but as far as temporal resolution, in other words, all those that deal with time information, for example, like in the case of brain information, as far as time is concerned, the best is still either the EEG or the NIRS. That will gives you a very good, what do you call that, understanding of the signal with respect to time, or else you will miss a lot of information in this particular case. For example, like fMRI, fMRI is very good as far as the spatial information is concerned. But when it comes to temporal, it will not produce you the best kind of results, okay? And then for PET and for SPEC, it is not very good information for temporal, okay? Spatial information, as far as EEG, is very poor. It doesn't give you the spatial information to that kind of accuracy that we want. But fMRI gives you an excellent, a very good information as far as spatial. For example, if you have trauma, tumor, brain tumor, then the only way to do it is fMRI. okay, or CT scan. Okay, that's the only way. Okay. And then, yes, PET is also possible for spatial resolution and so forth. Okay. So what does it measure? Mainly neural activity as far as EEG is concerned. Okay. But for fMRI, there is no direct relationship as far as a measurement that you do. So, but mainly for spatial. If you talk about spatial resolution, this is the best. Okay. And then how long can we measure? We can measure medium-term measurement. For fMRI, it's more short-term. And for PET, it is a very, very short-term or very short task. Okay. And then for the NIR, it's more long-term measurement. Okay. So you actually do it at a scalp for the EEG. And then for the fMRI, you actually do a deep measurement right inside. For the PET, you also do a deep measurement. Okay. And for NIRS, you also do a scalp measurement. Okay. The nice thing about it is as far as EEG is non-invasive. Okay. So is fMRI is non-invasive, but PET is partially invasive. Okay. And then SPEC also partially invasive. And the NIRS is also not non-invasive. The cost for the scan is actually very low, around $10,000, which is sometimes can be negligible. Okay, and then for the fMRI, of course, is very expensive, and then for the PET, is also very expensive, and for the NIR is more expensive. Okay, than the scan, the EEG. So those are the typical, and you can see here I have, for example, here the EEG signals. And because of the complexity of the EEG signals, you normally want to deal with both the time domain and also the frequency domain analysis. Okay. So therefore, EEG measures electrical potentials of the neurocortex. The functional measurements, you can actually do that. And many more. So I will go through some of these measurements as we go along. Okay. This is what the EEG is all about. Other than EEG, we also have EMG. Okay, EMG. But of course, as far as all this EEG, because we are just looking at the scalp, we can only measure what is happening at the outside. But what is important is that although we are measuring at the outside, this is how the brain actually, the neurons in the brain actually works. They don't work alone. Okay, they work in a group or in team. Okay, so if you find that the EEG signals, for example, what we measure like the brain here, you can see that the group of brain here is the one that create that kind of signal, and the synchronization of the signal from each of these neurons, and they work together, and they will actually give you the signals that we want to measure. In this case here, to give you the EEG. So that is why EEG are not measured with 10 milliseconds or 1 millisecond, but we measure EEG at 100 milliseconds. Okay. So therefore, that will give us the signal, and EEG signals are quite actually low frequencies. Okay. So the synchronization of this neuron, that actually works together becomes very, very important. And they refer to as the neurons firing together in a coordinated patterns, which in this case here produce a detectable oscillation of the brain waves on the EEG signals. So when a large group of neurons, usually this in the cortex area, like we know the frontal, the prefrontal, the parietal area, the temporal area, and the occipital area, which is the back of the brain here. Okay. And those are the areas that becomes critical in this case here. And when the neurons fires in sync, then you have all this electrical activity. They adds up together very nicely. So creating a very strong rhythm patterns. And these rhythm patterns are what we detect as the EEG frequencies. Okay. And the band, for example, you have the delta band, the theta band, the alpha band, the beta band, and the gamma band. Okay. So synchronization is actually the neuron firings at a similar rates and phase, and that become a very strong EEG rhythms. But when you have desynchronization, In other words, the neurons, when they fire independently. They don't fire together at phase. So therefore, the signal that you get is a weaker or disrupted EEG signals. So therefore, in this particular case, we cannot consider them as the EEG signals. Okay? So in synchronization, when the synchronization occur in EEG, we do have these 5 different bands. Okay, 5 different bands. Okay, the 5 different bands are the delta, which is from 0.5 hertz to 4 hertz. This one here is actually becomes very, very high, the signal, when you are in deep sleep. When you are in deep sleep. So therefore, high synchronization during the slow wave when you are sleeping, in deep sleep. But when you are awake, okay, when you are awake and that particular signal is very high, that means the delta signal is high, then I would recommend you go and visit your neurologist or neurosurgeon, because then some of the neurons in your brain is actually not functioning, okay? And of course, we have the theta wave, which is from 4 to 8 hertz. This is when you are drowsy, when you are meditating, okay? And synchronization is in the limbic and the midline region, okay? So therefore, this particular 4 to 8 hertz or the theta wave becomes very active. Alpha wave is when you are relaxed. We call it wakefulness. When you are awake, you are relaxed, okay? So the synchronization is in the occipital region. In other words, when you start to close your eyes, your occipital region will have the alpha wave to start to travel from the back area to the front area, okay? And this is what normally happen during eyes closed, okay? And then the beta is active thinking. When you are actively thinking, you are, trying to think about your research, trying to think about your study, then the beta wave will be active. Okay, so these are moderate synchronization. It reflects cortical processing. Normally, we don't deal with gamma wave. They are a little bit too high frequencies. So it's high level of cognition, fast local synchronization between region for a complex task. Okay, so we normally don't even consider, okay, the gamma wave. Okay, to give you some example or some flavor, okay, as far as the mental health issues, example, seizure. So these are excessive abnormal synchronization, especially in the delta and theta region. And these excessive can be very, very high. You will get a very high synchronization. It's abnormally high. So therefore, you know that there is a seizure that occur. So it's very excessive. ADHD, normally for those who have problem with attention deficit, okay, or hyperactivity, then often shows reduced beta synchronization. In other words, you do not have a good beta wave. So therefore, we have to talk about the theta beta ratio. Okay, later I will show you what is this theta beta ratio and how this theta beta ratio can identify someone with ADHD. Okay, that is why we said here reduce beta synchronization and excess theta. That means your theta beta ratio is very high. When your theta beta ratio is very high, there is a likelihood that you are a ADHD. You cannot focus, or you basically are hyperactive. Okay. Depression, altered synchronization patterns in the frontal region. So that means in your frontal region here, you can see a lot of synchronization patterns shifting. Okay, whether it's at the beta region or alpha region or even theta region. Okay, Alzheimer, reduce global synchronization, especially in alpha and beta bands. Okay, so these are some of the things that people have done, and they have taken a look at those, and they said, hey, these are kind of guidelines to say that, hey, these are the people with issues on mental health, and these are the things that we have found out. Neuronal synchronization underlies all major EEG rhythms. We must have synchronization in order to have EEG rhythms. I think that's what it is. So it supports cognitive process, attention, memory, and consciousness. That is why when doing something like that, we can also do the 5-factor identification based on the brain patterns, okay, which produce a very good correlation in this particular case, okay? Okay. EEG sensitive but not specific. sensitivity. EEG is highly sensitive, okay, in detecting abnormal brain activity. For example, if someone is having a seizure, okay, the EEG will likely show abnormal electrical pattern associated with it. It can also detect subtle type of changes in brain activity and related to encephalopathy. In other words, brain dysfunctionality. Okay. Now, specificity, on the other hand, is, however, EEG abnormalities don't always tell you the specific cause or the location of the problem. It just gives you a rough idea. In other words, somewhere along this region is where you have problem. For instance, an EEG might show slowing of brainwave, indicating that you have some problem. So, but it won't necessarily reveal whether the cause is a stroke, infection, or another condition. Similarly, epileptiform discharges, abnormal electrical patterns associated with seizures can be very, very high, okay, on the EEG. But it doesn't always mean that the person has epilepsy, okay? So other conditions can also cause this discharge, and they can even be found in some healthy type of individual, okay? Okay, I'm going to switch gear, and we're going to talk about this delta wave, theta wave, alpha wave, and beta wave. And beta, for beta, I will break it down into two. We have the beta, the lower beta, and the high beta. You can see from here that as far as the wave is concerned, when we talk about delta wave, these are the delta wave. They are very low frequencies. You can measure, if you want to measure, you measure from this particular region all the way to this region here, and this is one cycle, okay? And your one cycle here tells you what is the frequency. Now, similarly, if you have a theta wave, you measure one cycle, your one cycle is right there, okay? And for your alpha wave, your one cycle is right there, which is shorter. And for the beta wave, of course, the one cycle is even shorter. Okay, and high beta, that means it's even much, much shorter, okay, in this particular context. Okay. Now, key aspect of the EEG interpretation, you can do it with frequencies. In other words, you take the EEG signals, and then you are going to do some analysis with it. By analyzing the fast Fourier transform. You can do a fast Fourier transform. Okay, so the EEG signals are categorized into different frequency band. You have the delta wave, theta wave, alpha wave, beta wave, and gamma wave if needed. And then each of these associated with the different states of consciousness or the brain activity. So from there, once we get the signal, we can then analyze and make comparison. One of the comparison we can do is like measure the theta beta ratio, or measure the alpha beta ratio. Later, I'll show you why this particular ratio become important and critical in this particular case. The shape of the waveform, or you can do a morphology analysis. In other words, you do a time domain analysis. In time domain analysis, you actually study the shape of the waveform itself. For example, the sinusoidal, whether it's a sharp or you have a spike, okay, and the wave provides information about the underlying brain activity and the potentially abnormalities, the potential abnormalities. Location, we do not go for the exact location, but we go for the distribution of the location. In other words, when you look at the scalp, it is crucial for identifying localized brain activities with that 4 different areas that we talk about. Remember, we talk about the frontal area, we talk about the parietal area, we talk about the temporal, and we talk about the occipital. So those are the areas or the critical areas that you want to seriously take a look at as far as the EEG is concerned. Example of the morphology here you have, for example, you study shape. You study the shape of the, what do you call that? In this case here, the shape of the, the amplitude, and then the period itself. Okay, so you study the period and the amplitude, and then you try to see what are the kind of differences and so forth that you get. Okay, so from these morphology studies. Okay. And also you can take a look at, for example, here you have the gamma wave. You can see there are a lot more waves, but the beta has less. The alpha is even much less. and then the theta much less, and the delta you may only have one period. You see down here, one period. Okay. So but you will see that that is not an exactly sinusoidal wave. Okay, the wave actually, yes, it is stretchable and so forth. So that is why analyzing it at just the frequency domain may not be sufficient to really gives you a better understanding of what is going on in the brain. Okay, these are some of the slow wave. As far as we are concerned, I can show you some of the slow wave, and these are all the fast wave. Okay, so you can see the fast wave here. Okay, they're very fast. And then for the slow wave, okay, you can see that you have the delta wave coming up, and then here all the theta wave and the alpha wave. Okay, so those are how you actually read this kind of signals. Okay, and then you take a look at the amplitude. That means as far as the peak value, so we try to understand the peak value, and then also the negative peak and the positive peak. Okay, and then from there we start to identify. So brainwaves can be described using combination of amplitude, okay, and frequencies. Okay, how often a brain waves approach with a time frame or frequencies, it is measured in hertz anyway. Okay, so therefore you have a very good idea as far as the fast wave and the slow wave and the combination of the fast and slow wave, and see how the activity actually affect the brain in this particular case. Okay. Okay. Normal versus abnormal. Specific frequency ranges and waveform morphologies are considered normal for awake, okay, related adults, for example, your alpha rhythm, okay, while others associated with sleep stages, example, delta and theta rhythms, or certain brain disorder, like epileptic type of seizures and so forth. So in this particular case, you will have a big spikes. Suddenly the signal goes up as far as the theta wave is concerned, and it becomes very high. And then you know that you have a seizure. Okay. But seizure, normally before seizure occur, there will be this thing called SCP. SCP is a very slow wave. The very slow wave, it is like less than delta wave, about maybe 0.4 to 0.2 hertz. Okay, so a very slow wave. And then once that thing occur, then you be prepared that there may be a seizure or attacks coming up. Okay. Abnormal waveforms in specific location can indicate underlying pathology such as focal epilepsy or stroke in this particular case. Okay, seizure activity. I mentioned about seizure just now. So in other words, EEG can detect onset and spread of seizures. So identifying the type of seizures, in this case here, you have to include SCP, the slow moving wave. Okay, and this slow moving wave can actually predict when seizure is going to occur. Brain death, in some cases, extremely slow or absent brain waves activity can be indicative of brain death. Like, for example, like I mentioned just now, that delta wave, when you are wide awake, then this could be an indication that some of your neurons are dying. Okay. Artifacts. EEG interpretation also involves recognizing artifacts, example, muscle movement, okay, activities. Like, for example, when we do the EEG measurement, if you are, what do you call that, trying to bite your teeth, when you try to bite your teeth, and if it is on the left side, then we can actually measure the EEG from the left side. We can see a very high theta wave in this particular case, okay, or sometimes beta wave. When you actually do something like that. Okay, so we have to be careful. In other words, when you do EEG measurement, you have to know, okay, what is going on. Here I have, for example, I mentioned about the slow wave. Slow wave are between 0 to 1 hertz. Your delta wave is between 0.5 to 3.5 hertz. Theta wave is between 3.5 hertz to 7.5 hertz. Your alpha wave, which is the normal wave, should be around 7.5 to 12 hertz. Okay, and then your beta 1 and beta 2. Okay, so those are the frequency band that we normally analyze in this particular case to give us some idea as far as these mental health issues or problem that we are facing. You can have this kind of probes. okay? Or you can even have this kind of probes. This one here is quite popular now. They actually read your what do you call it, the frontal area. You have the FP1, FP2, FP3, FP4. So those are the 4 frontal that you actually want to measure. And you can move around with it. You can do your jogging, you can do your walking, you can play badminton even, to see whether you have a very good brainwave or not, and whether the brainwave is getting better or worse and so forth. You can do that. Okay, and these are available. One of them is using the Muse. The other one is using the Neuro, Neuro. Okay. And we actually uses the 1020 placement, okay, by which you can see from here, from the center of the eye here, from the center of the eye. In other words, you do the measurement 10%, 20%, 20%, 20%, 20%, and 10%. Okay, but nowadays we use the cap. We use the cap. So with the cap, it's much easier for those who are not familiar to do the measurement. So similarly, with this, what do you call it, on the side here, left side and right side, we also do the same thing. We have a 10, 20, 20, 20, 20, 10 rule. Okay, so that's the measurement, and then we take those measurements from there. Okay, so that's the 10, 20 system. Okay, the activation state of the brain, you can see from here the frontal area. Okay, like for example, I have the delta wave, I have the theta wave, I have the alpha wave here, I have the beta wave and the high beta. And we are in this particular case concentrating on the frontal area. Okay, so you can see if you are deep sleep, your delta will be very high. If you are relaxed, and just about to go to sleep, then you find that your theta is very high. Okay, and then the alpha is the wakefulness. Okay, and then beta is when you start to think, and then high beta is when you are angry in this particular case. Okay. Okay, so let me continue. So the delta wave is the one that actually is a very slow wave, and these are the basic brain wave that when you are awake, almost not present. Okay, almost not present. But when you are in deep sleep, yes, it becomes very high. Okay. And then the theta wave frequency between 4 to 7.5 hertz is a slow wave. Okay, of course, faster than the delta wave. And theta wave are present in state of fatigue and sleepiness. When you are very sleepy, you will have the theta wave coming up. And general underactivation of the nervous system. Okay. And then your alpha wave is the default state brain wave. Okay, and it is actually what sometimes we call the standby mode. Okay, standby mode. It is prominent in the eye closed condition, which physiological inhibition. In other words, when you close your eye, you can actually see is your alpha wave actually goes from the back here and it will travel towards the front. Okay, so that's what it is. Yeah? Okay, let me show you some of the common EEG patterns in anxiety. Okay, just to give you some idea. Okay, that anxiety, several common neuro traits as far as appear frequently in anxious individual. Okay, is increased high beta activity. Okay, that means from 21 to 30 hertz. So fast wave overactivation, especially in the frontal area and the central region, okay, is a hallmark of anxiety. This reflect hyperarousal, okay, worry, excessive cognitive processing, panic, or overthinking. Okay, and then there is a reduce in alpha activity. Okay, you can see also the alpha activity is reducing and so forth. So this one you can read on your own. I'm not going to go into the detail. Okay, as far as giving you the understanding what will happen when you have anxiety. And then the other one is depression. Okay, you know that when you have depression, these are some of the things that can occur as far as depression is concerned. Okay, and some of the depressions and the brainwave. So you can see that the frontal alpha symmetry, for example, like the left side and the right side may have different activity. Okay, in other words, the degree or the measurement, the power of the alpha wave is going to be different. Then you know that, hey, this individual has got depression. Okay, excess theta or alpha activity, okay, can also be measured as far as depression is concerned. So which is quite interesting. Rather than looking at the beta wave, you can see that in this particular case, the alpha asymmetry becomes important and critical, and even the excess theta, okay, or alpha activity can be actually an indication, okay. So increased beta activity can be an indication in this particular case, okay. Okay, let me move on to give you some idea. These are the things that we need to basically understand and we need to know before we can do any kind of neurofeedback and so forth. Okay. Let me just go very quickly in this case here. Okay. They all give you all those information, then they are very useful. Okay. Here I have for example, I want to estimate IQ, okay, for cognitive ability. Then I can use the alpha power between 8 to 13, especially in the parietal and occipital region. Okay, so higher alpha power often correlates with higher IQ, which is quite interesting. Okay, and then your peak alpha frequencies. That means the frequency with the highest alpha power. So the faster peak alpha frequency, that means closer to 11 to 13 hertz. Then this one here tells you that this guy has higher IQ. Okay, because your alpha should be around 10 hertz. But now your alpha has shifted to around 11 to 13 hertz. So therefore this guy, could have. Other than it could be stress also. Okay. So theta and beta ratio. Theta beta ratio here is being measured for someone with ADHD. Okay, if you have ADHD, then normally we will measure your what do you call that, the theta beta ratio. Okay, and then event related potential, the ERP. So the brain responses to specific stimuli. Example, the P300. I'm not going to talk about the detail as far as the P300 and 200 and so forth. Okay. So all this, if you want to know more, we can always discuss. Okay. The frontal parietal connectivity measured by the coherence or stronger front to parietal network are found in high IQ individual, okay, and so forth. Okay. So a lot more information you can actually read on your own here. I will leave the slide with you to actually go through them. So like here you have the alpha power, okay, and so forth, which some of it we have been discussing. Okay. Okay. This is the NeuroCoach Digital Lab. Let me see if I can display them.
Welcome to the future of well-being, where science meets compassion and innovation transforms life. Let's take a tour of our lab. This is Shahida, the EEG assistant of India. This is where it all happens. Our neural room, the heart of NDL. Equipped with our EEG devices, this is where we can measure your brain signals. This is the living room where clients can kick back and relax while waiting for their appointments. Our goal is to provide you with the utmost comfortable experience you can have. Every day, we embark on a journey to enhance life, whether it's developing groundbreaking neurofeedback techniques, conducting in-depth EEG assessment, or exploring the latest advancement in mental health. We are here to guide you towards a healthier, happier you. NeuroCoach Digital Lab, empowering minds, transforming lives. Visit our website or contact us to be a part of this remarkable journey.
Yeah. Okay. So that's the NDL lab, which is in the Kuliah of ICT in IIUM itself. So if you ever visit IIUM or UIA, come and let us know so that we can actually open up and show you our lab. Okay. Okay. I want now to switch gear and go into the analytics part. if you look at the psychological valence and arousal, okay, that means if you look at emotion, you can break emotion into two basis function, okay, which is the arousal itself and the valence. Valence, you have the negative valence and positive valence. In other words, happy compared to maybe fear or calm, okay. And once you can break it down, you can see that, for example, stress. Stress is positive arousal and negative valence. Okay. Anger is also negative valence, positive arousal. Okay. While you're talking about happy, okay, is on this particular region. We are talking about the positive arousal and positive valence. Okay, when you are calm, you are on the positive arousal but negative valence. And when you are sad, for example, so that will be on the negative arousal and positive negative valence. Negative arousal, negative valence. Okay. So give you some idea, these are the affective space model that developed by Russell. Russell is a psychology a long time ago. So they have this two basis function, the activation, deactivation, and the pleasant and unpleasant type of valence. Okay. But you can also relate all this functionality, okay, to movement. For example, like when you are shaking your hand, less shaking or less pressure shaking your hand, then this is more positive arousal and positive valence. Okay. But if you swing, instead of shaking, you swing, then swinging is more like calm. So that will gives you the positive valence and negative arousal. On the other hand, if you are high pressure swinging, then you see that you are actually having a negative arousal and negative valence. Okay. And then if you are high shaking with high pressure, then you are on the high arousal or positive arousal and negative valence. Okay, so that's what it is basically in translating from the affective space model, Russell affective space model, okay, as far as movement is concerned. Okay, here I have a picture of learning disabilities. I want to start with autistic children or autism. Can you see where is the autistic children? Which one? The girl or the boy? No, no one knows. Actually, it's the boy. The boy behind here is actually autistic children. And he will not want to talk to any person. Okay, he will always look down. Okay, so these are typical of the autistic children. Okay. So therefore, why do you want to actually do this early detection? So early detection of ASD for Asperger's syndrome can help for us to identify, because when we can identify early, we can do early intervention. And early intervention, and hopefully with that early intervention, we can correct some of the situation, and this individual can be far better off, okay, because of the early intervention. So we can correlate between emotion, motor skills, okay, and also the advanced correlation. The correlation between emotion, motor skills, between ASD and the control subjects, okay, can be very interesting. Later I will show some results. Important and meaningful feedback for early detection, okay. Early intervention, as I mentioned, can normally help these children, okay, with disorder to lead an almost normal life. In other words, if you can identify, and sometimes this thing here can help, okay, and in most cases, the children can live like a normal person, okay, like a normal person, much easier, okay. So one of the intervention that we suggested was to use the multimedia intervention for self-intervention and also neurofeedback, okay. Okay, these are some the basic methodology is basically, if you look at this, we have the data collection, okay, using our EEG device. We have the 8-channel, we have the 13-channel, and now we have the 4-channel frontal type of device also, okay. So therefore, if you want to do any experiment in this particular case, come and let us know, okay. You can come over and then we can do some experiments together, or you can even do it on your own. This pre-processing here is important and critical. Why? Because you have to throw away all those artifacts. Something that you do not want, you want to throw away. Okay. And then we extract features. And then from the feature extraction, we can do a lot of training as far as the features that we have extracted. Okay. These are some examples you can see here. We are working together with the Penawa Hospital in Pasir Gudang, Johor. Okay, so we have these particular kids. They are watching the movie, this video, sorry, watching the picture. This International Effective Picture Standard, or IAPS, is the one that we have been using so that we can determine whether this is happy, fear, calm, or sad. Those are the 4 quadrants that we're talking about. So from that 4 quadrant, we can now extract the valence and arousal. Okay. So here you are. Here you have another student here. Okay. And this is at Penawa Hospital. Okay. This is another example of what we do the measurement. And because of this headset, it really helps a lot to expedite as far as our measurement are concerned. Okay. Okay, some experimental setup. We collected using our BMAC EEG devices. Okay, and we actually do it in a quiet room. It has to be a quiet room. And we have 12 subjects. Okay, 6 of them are autistic and 6 of them are non-autistic or normal children in this case here. The age is around 7 to 9 years old, so they're quite stable. As far as the EEG signals are quite stable. Because if your age are much lower, then the EEG signals may not develop yet. Okay, that's why you see some of them, you cannot measure very accurately in terms of the EEG signal, because especially the alpha wave actually shifted towards the lower end, not the higher end. Okay, and we can match the IQ level. We ask the parents, okay, what are the IQ level of the student, what they can do and what they cannot do, okay, and so forth. So we use the Stanford BiNet 4, okay, in this particular case. And our protocol consists of eyes open 1 minute, eyes closed 1 minute, and then first emotion stimuli, second emotion stimuli, and then imitation emotion stimuli, and then you have motor imitation. The imitation here is you just ask the children to follow by you moving your hand like that. Okay, so they will start to follow. Okay, you have the fine motor movements. Okay, and also how this guy can duplicate whatever movements that you want them to do. Okay, so those are the things. So with that protocol, it's much easier now for us, because this protocol, we have actually worked together with the psychologists in that protocol. The results is kind of interesting. We analyze and we extract the valence. When we extract the valence, okay, these are the one that comes from the normal children, and the dynamic movement of the motor learning imitation for the normal children. Okay, they actually, if you notice here, this is the arousal scale. Okay, and in the arousal scale, this is the normal children. You find that they actually vary. Okay, very nicely. But for the case of the autistic children, okay, there is almost 90%. Okay, is actually right there. Okay, in other words, they actually have more negative arousal rather than positive arousal. Whereas in the case of these particular children, which is the normal children, they have positive, negative arousal. You see, positive, negative arousal. Okay, so that means the arousal must change. With that kind of positive, negative arousal, then you find that, hey, these are more quite normal children. Whereas we found that this individual who is autistic is actually mild autistic. When we do the measurement, initially it's very high, and then after that it goes to very, very low. Okay, so which is kind of interesting, and it remains there. Okay, after that. Okay. This one here is the arousal. Okay, we combined all those between the subject which have autistic and subject which are control subject or normal subjects. Okay, So we can see the plot are very different between the control subject and also the what do you call that? The autistic children. Okay. As you can see, the red color here are all the autistic children. Okay, and the blue color, the light blue, the green color, and so forth are all the control subject or normal children. Okay, so we try to plot them, and you can see easily here that you can identify by looking at the arousal alone, okay, whether this guy is autistic or non-autistic. Okay, so that's very interesting. Okay. Okay, now let me summarize. What we have done is we have taken a look and we can discriminate between just by looking at the arousal between children that is autistic and non-autistic. Okay. Okay, I will now move here, but this time I want to detect autistic children by using a different kind of methods. So in this particular case, I take a look at the what do you call it, the EEG signals. I get rid of all the artifacts here. I put through a band pass filter so that I can extract delta wave, okay, theta wave, alpha wave, beta wave, and gamma wave. So after extracting all that, then I extract the features. Once I have the features extracted, then I do some kind of classification. Okay, so this classification will allow me to classify between, okay, ASD children, okay, which have a U-shape, a very U-shape, unique type of, what do you call it, patterns, okay, in this case here, or a normal children, okay, in this case here with the N-shaped patterns. So we base on the findings that if you have a U-shape of the alpha, theta, alpha, and beta. Theta, alpha, and beta. This theta, alpha, beta wave will give you a U shape. Then you know that this one is autistic. If it is an N shape, then you know this is basically normal children. Okay, and that's how we actually measure them. So from this, we do 4 basic emotion: happiness, fearness, calmness, and sadness. And then based on the IAPS, we actually extract those emotion. And from there, we actually extract the valence and arousal. But we make use of the arousal and not the valence, okay? And with the arousal, we can now identify, this is according to the published work, you know, that if you have ASD, autistic children, then you have a U shape here. Can you see that? Between the theta, alpha, and beta, okay? And then if you have N shape, like the blue color here, then that shows it is a normal children. Okay. So we did the same thing with the real one, with the control subject, okay, and control 1 and control 2. Unfortunately, for control 1, for example, here, you cannot see any N shape or U shape. You just see a straight line. Okay, but at least for this one here, you find that there is some kind of a U shape here, right? At the end especially, okay? And for the ASD subject, you can see down here, the ASD subject, you have very clear U shape. Can you see that? Very clear U shape. And here you have some kind of a U shape here, although not very clear, but you know it's a U shape, okay? And then we make comparison. But this time round, we actually introduced this NPIA, which is the neurophysiological interface of affect. We actually introduce our own way, our own techniques, okay, and looking at the arousal. So we look at the arousal and we can see from the arousal the distinct N shape here. Can you see that? Okay, and for subject B, we get here you only see a very slight U shape, but here you can see a very good U shape. You see that? So that very good U shape tells us clearly that this is an autistic children, and this one here is a normal children. Okay, and then we plot them, and then we make comparison between the ASD executive function test, and then we can plot here. You find that these are the alpha beta ratio. Okay, so from the alpha beta ratio, we can also estimate whether it is autistic or non-autistic. And then after that, we do the eyes closed. So what we have here is the eyes open. So now we do the eyes closed. With the eyes closed, okay, can we still detect the differences between autistic children, non-autistic, as far as the U shape and N shape, okay, in this particular case? So we have identified, and yes, we can really identify the differences. So comparison tables of existing models and proposed NPIA model in table 1 and 2, okay, figure 2 and figure 3, results for eyes closed and also eyes open shows that, yes, you can identify quite distinctly between the autistic children and non-autistic children. On inconsistency in results for subject C and D, for eyes closed and eyes open, respectively, shows the robustness of the NPIA, because the NPIA can detect a better detection as far as the differences between autistic children and non-autistic children. Okay, so therefore the NPIA is quite a good alternative. Although existing time domain methods have been used together with the alpha beta power ratios, there seems to be some marginal cases that NPIA are far better in this particular case. Okay. Let's do another detection, but this time, what we're going to do is we do a LD detection using computational neurophysiological of effect. Okay. Now, CNPA, we call it CNPA. Okay. So what we did was, again, we do the same thing. We do the pre-processing. We extract the features, but this time we use the male frequency capture coefficient, the MFCC. Okay, and then after that, we set the target, whatever that we want. Okay, and then from here, we try to identify children with autistic, children with ADHD, and children with dyslexic. Okay, based on published type of work. In other words, like for the ADHD, we try to detect the theta beta ratio based on the NIBA standards. And then for the dyslexic, you start to identify between the left side and the right side of the brain and see whether there's any differences. Okay. And then for the autistic children, okay, like we do the brain measurement. Okay. For the children that actually have the U shape or the N shape, like what we did previously. Okay. So for dyslexic, the left brain and right brain. For the autism, we have the alpha beta ratio. And then for the ADHD, we have the theta beta ratio. So all these are well-established work that has been done. Okay. And with the diagnosis that we do, so we check with the diagnosis from the psychiatrist. The psychiatrist indicate these are the subject, A, B, C, D, E, F, G, H. Okay, the first one with the autistic in this particular case. And then the second one is mild autism spectrum disorder. And then C, subject C, ADHD. Subject D also ADHD. And then we have dyslexic. And then the rest of the other subjects are normal. We make comparison with our EAG method. In this case here, we use the arousal detection. Okay. For the autistic children, yes, we identify the same thing. For the subject B, it is similarly. And then for subject C, in fact, we identify that other than ADHD, but he or she is also dyslexic. Okay, he is also dyslexic. And then for the subject E, is also dyslexic and ADHD. Okay, whereas the rest are all normal. So therefore, we can identify using the NPIA, in this case here, our method of identifying, that we can identify between normal children and children with disabilities, especially learning disabilities and also with the focusing disabilities, okay, and also dyslexic. Okay, so we did the same thing. This is for the positive emotion, then this is for the negative emotion. Okay, we can still identify them. So emotion, basically, we have identified them very nicely, and we can use them whenever it is needed in identifying children with learning disabilities. Okay. Emotion to stress, which is interesting that, we try to understand stress. But first, we need to understand whether we can measure stress together with emotion. Okay. In other words, if I can have the emotion or the valence and arousal, can I in this case predict stress? Okay. So understanding emotion stress from the trajectory of valence and arousal can help profile patients. For example, your pre-emotions or precursor emotion, okay, can have better important role in learning experience. The mean emotion can help stress management through awareness and management. I also have, and the last slide, I will show you how we actually make use of the EEG to identify individual, a group of individual, the eustress and distress. Eustress and distress. Because if we can understand the margin between eustress and distress, that means these are the area where you can be optimized, okay, as far as your learning experience in this case here, okay. Same, we use the 20, but this one is adults rather than children, and this is without the cap, okay. So you actually do all the measurement without a cap. So we have to measure using the 10-20-20 rule, okay. Same thing with the this direction, and also from here all the way to the back. Okay, so we measure and take the 10-20, 20-20-10 rules. Okay. And then we try to measure stress. In this case here, I will just cut it short. And just to show you, we extract the valence and arousal using feature extraction and also some AI techniques. Okay. And then from there, we try to identify emotion. But we want to extract the whole idea, not just identify emotion for stress, but also identify and using emotion for the purpose of identifying 5-factor behavior. Okay, 5-factor behavior. So these are the 5 factors we have behavior. We have the neuroticism, extroversion, openness, agreeableness, and conscientiousness. So we try to correlate by looking at the valence and arousal and see whether I can correlate or not. This one here, whether this particular individual is neurotic, is it extrovert, openness, agreeableness, or whatever, conscientiousness. Okay, that it has. So the way we do it is we're gonna make use of this emotion, the happy, fear, calm, and sad. Okay, and then we're going to use the EEG subjects. Okay, and the EEG data will come, and then we try to analyze them, and we break it into the valence for happy, arousal for happy, valence for fear, arousal for fear, valence for sad, arousal for sad, and valence for calm and arousal for calm. Okay, so with that, now we can already extract the valence and arousal information. Okay, on the personality side, so you have they will actually do the questionnaire. After they do the questionnaire, then we can extract like NEOAC. Okay, what is the value of NEOAC? And then see whether we can correlate between this one here to this one here. Okay. So let's start with the raw data. In the case of the raw data, you can see these are all the raw data of the emotions and so forth. You're pre-processing it, remove all the artifacts. Okay. And then you extract the features using MFCC. And then after that, you set the targets that you want to actually get the valence and arousal for fear, calm, fear, happy, fear, calm, and sad. So these are the 4 quadrants of the emotion that we want to analyze in more detail. Okay. In the experimental setup, okay, we actually have eyes closed, eyes open, 1 minute each, and then 4 minutes, 1 minute each of the happy, fear, calm, and sad. Okay, and then after that, we ask them to do the personality test. Okay, and then we measure the EEG. EEG, we collect the data. So from this, you know that you can, from the score, from the score here, you can measure whether this guy, for example, is neurotic or not. Okay, if it is neurotic, very neurotic, then yeah, this is in the region. You have 1, okay, 2, okay, and then of course 10 or lower, then you have problem. Okay. And then after that, instead of just measuring the score, we can also use the plus minus. So we use the trait type. In the trait type, I have low or high, +1 or -1. So those are the things that I can actually use, okay, also to measure. And then after that, I do a correlation. You remember from the diagram here? Yeah, we do the correlation. And that's exactly what we are doing here is we do the correlation. Okay. And then from the correlation, I can see now that, hey, we have our valence arousal and we try to correlate, okay, with this particular graph. So having to do the correlation in this case here, we can extract and we can predict as far as whether this guy is neurotic or this guy is extrovert and so forth, and we do something like that, okay? With all that measurement, in the end, we have this particular summary of the results. For the neurotic, okay, if I want to know this individual is neurotic or not, I can make use of the arousal for come. Arousal for come. Once I measure the arousal for come, and then I can use this model, okay, and I can extract whether this guy is a module of come or not, okay? And then I can use T-score. I can also use trait type. That means the plus minus, okay? So those are the two. And then with that, and these are the model that I can use. And in the end, I can extract about 10% error. Okay, there could be 10% error that this guy is not neurotic or is neurotic in this particular case. The next one is extrovert. Extrovert is very good. You have about 5% error only. So very low. The error is very low. But you have to make use of the valence of sad, valence of calm, and valence of fear. Okay, so once you have the valence of all these valence, you put it into these numbers and you can straight away find whether this guy, okay, is having a neurotic extrovert or not. Okay, the only thing we couldn't identify is agreeableness. Agreeable because all the students that we have are actually a university student, and it seems that most of them are not agreeable, not easily agreeable to whatever that we said. Okay, which is good, because if the university students, almost all of them is agreeing to whatever we said, then that's bad. That's bad. So at least down here we know that, hey, our students are not that bad. Okay, and then you have conscientiousness. Okay, but if you use the trait type, we can do a good measurement. But if you use what do you call that, the T-score, then very difficult for us to do a correlation. We cannot correlate very well. Okay. So in the end, this is what we have. Okay, so we can, in other words, look at behavior by looking at the emotions. Okay, that means the valence and arousal. Okay, by looking at that, we can straight away identify the kind of behavior. Okay, so rather than using the questionnaire, because the questionnaire may not be sufficient. Okay. Okay. Summary and conclusion. I want to, this is the one that I mentioned about eustress and distress, one of work by my PhD student. If we can try to identify, in this case here, can you see that? This is the area where you have the eustress. That means focus, attention, emotional balance, and so forth, okay? So with this, you can optimize your study, something like that, okay? That's what we are hoping for, okay? And then the perception of stress, what we did was we take a look at the perception of stress, okay? Survey for 8,571 Malaysian, okay? And then stress perception in different age group, okay? Young adults, okay, have highest perception of stress in 2023 after the COVID, okay. Okay, now, in this study, what we're trying to do is, like I mentioned, we want to know the eustress, optimum of the eustress, okay? That's basically what it is, okay? So I'm not going to read the rest, okay? And then in order to do that, what we have is we actually have on total 109 subjects, 109 subjects. And then there are 109 subjects. most of them are university student, either undergraduate or postgraduate. Okay, Malaysians and non-Malaysians is 50-50. Okay, and then the age is between 23. Okay, you also have age less than 21, 22 to 28, and 28 to 35. Okay, not too bad. Not too bad. Okay, first we did SAM. SAM is the what we call the self-assessment mannequin. Self-assessment mannequin. In this particular case, you can see that here, the picture here shows a negative valence, okay, and positive valence, okay, up to +4, okay, or you can have negative arousal and positive arousal. Positive arousal means, yeah, you're very aroused, you know, so you can do that. And we take this as one of the points that we want to also measure, okay, and the perceived stress scale, okay, we did that also. And we measure them and we get the scoring here as far as using the PSS, the academic eustress, academic distress, adolescence distress, and the both eustress and distress scale. So these are the 5 different types of scale that we use to analyze our student at that particular point of time. Okay. And then we plot, and you can see from the plot here that these are the probability distribution. And this one here is for eustress, high eustress, okay, low eustress, and medium eustress level. Okay, and then we have the distress level, and then you have again, this is the combined eustress and distress level based on SAM, self-assessment mannequin. Okay, so that's the results. More results. Okay. But what I want to show you here is that you can see from here that hey, I can do a correlation. Okay, and some of these correlation are quite good, but of course some of them are not very good. So in other words, whether it is significant or not, so we can take a look at them. Okay. So in this case here, we have for emotion variable for SAM. These are from SAM. You can also extract the valence and arousal. Okay, and then for the academic distress, only valence are used. Okay, valence are used. This one, sorry, arousal are used. This one here, valence and arousal, valence only, and valence only. Okay, so these are some of the errors that we're talking about, and here the errors can be around 12.36%. So that's quite interesting, actually, as far as the error is concerned. This is only using the SAM. Okay, then after that, we actually extend the whole idea, and we now make use of the EEG. Okay, make use of the EEG. And then we sample the EEG, in this case here, the brainwave, okay, out of 33 subjects. Okay, we extract those, and then those below 70, we throw it out. We don't want to actually use them. Their data. Okay, but those above 70 are the one that we are actually using the data. Okay, so those are the subjects that we do not use. Okay, and other subjects we actually make use of them. Okay, so here you can see the perceived stress scale. Okay, if I use the valence, okay, and this is for fear. Okay, I can actually get a significant type of correlation. Okay, and here for calm, and then here for ADS eustress. Okay, and so forth. So once you have done that, we can now extract the model. Okay, as far as the perceived stress and academic eustress and academic distress, we can extract the model. And you can see here for the academic eustress and distress, you have both the model, which is already available. Okay. And with that model, right now, We continue doing that with arithmetic task, simple task, difficult task, and so forth. And we try to correlate with the what do you call that? With the stress scale. Okay, you stress or distress. And in the
I'm
end,
sorry, Prof.
yeah, go ahead.
The time is the run out. Maybe the the next session is the question and the answer session, Prof.
Relaxation.
Yeah. The next session is the Q&A. Because the time is the run out.
Oh, okay, 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 okay.
Uh,
Okay, I
okay.
will
I'm
end. This is the ending part. Okay,
okay
so
then.
therefore, in this case here, we have, remember, we talk about the distress, okay, the eustress and also distress. So this eustress area is something that we would like to have. And in this case here, we can measure eustress, and this is the region of eustress for this group of students that we have actually do the analysis. So with that kind of analysis, so we know that, hey, in order to optimize, okay, the student performance, this is the area that you can actually do for the eustress and distress. Okay, so yeah, these are the detection, and we have also analyzed and produce the model in this particular case, and the model can be used. Okay, so this is a summary, and basically on conclusion, these are the contribution as far as the thing are concerned. Okay, okay. Is that what it is, or do I have time, or I don't have time? You want to ask question first?
Yeah, the next session is the question first, Prof, for the
Okay.
participant. So, ladies and gentlemen, we have the end. So, ladies and gentlemen, thank you very much for the Professor Abdul Wahab Abdul Rahman, the insightful presentation. We will now open the question and answer session. Participant may ask the question by using the raise hand feature, or the writing question, the chat box with the format name that question. Uh,
Is there any question yet or not?
Yeah, sir, the question from the Dava Sidki Tamrin, the question is I would like to ask about the mental health and the EEG analytic, because I think the topic is very relevant to our life. Regarding mental health itself, I feel that in this era of the social media, mental health is becoming more vulnerable due to the high standard expected by many people. Condition and the password different from today with minimal social media, so there were no set standard to follow. My question is over the current young generation, especially Gen Z and the subsequent generation, who are the often criticism by older generation after older Gen Z is currently is the past of the development and grow additional what the role can technology play as the tool to prevent mental health issue, especially since many people still view visiting and a psychologist as the usual action. Uh,
Yeah, I think one of the biggest issue right now for mental health, is that
Siapa yang paling mengkritiki Gen Z gitu kan ya? Gen
macam mana? Okay.
sekarang
uh, the question is from the chatbot. The Prof to answer the question from the Nafa Sid Kitamri, please, Prof.
Hold on, because I think the topic is very okay. What advice and motivation can we offer to current young generation, especially subsequent generation who are often criticized by older generations? Actually, as far as technology is concerned, that's why I said what I'm trying to say is that if you look at the younger generation, the younger generation, with all these games and so forth, their focus towards real life is getting less and less. They are more towards imaginative type of situation. Okay, when they play games, they have been too engrossed in the games, that they forget about the real life situation. So what my suggestion, especially for the younger generation, the very young one, we're talking about those in the sekolah apa tu, secondary school, secondary school, for example. In the secondary school, I would like to offer, in this particular case, we can measure the brainwave patterns, okay, to determine whether this particular individual has got problem, mental health issue, okay. And that is what we are doing in terms of the NDL. The NeuroCoach Digital Lab is now doing that. Okay, so we invite the public to come to us, and then we do pre-measurement. In this pre-measurement, we can see the kind of issues that we have, and we start to profile every individual. By profiling this individual, or we call it gamification. So we then have a good idea, okay, as far as the group of individual that is within that area, the kind of mental health issues that we have, okay? And we have to handle them. In addition to just doing the pre-measurement, doing neurofeedback to help them and so forth, we also have games. We introduce games so that games we can identify through games based on the psychological framework, okay? Then you can have a better idea whether you can have anxiety, you can have depression in this particular case. And if you can identify them, that will help a lot in terms of the psychology and the psychiatrists, because we don't have enough psychiatrists and psychologists to go around. Okay, good one, especially. So this is what we are trying to do. So therefore, the end part here, if you talk about technology in trying to help, these are the things that you can do. These are the things that you, as a master student in the end, can help by either looking or develop expertise in terms of brainwaves, or develop expertise in terms of generating or design games that not only help you identify, not only they play games, but at the same time, you can help identify things like anxiety, things like depression, things like suicidal cases. How can you predict suicidal cases? These are very important cases, and only through games can you do it. Okay, and then we confirm it with the brainwave patterns. So that's what we are doing right now. So we are having some grant and money where our master student, our PhD student, are now developing games for that particular purpose. Okay, and we try to correlate everything exactly to the brainwave itself, because that gives us a better perspective in terms of the relationship. Okay, so especially suicidal cases, there are a lot of suicidal cases that happens not only in Malaysia, anywhere in the world, even in Indonesia. I'm very sure there are a lot of cases like that. Okay, so this is what the thing we can do. So does that answer your question?
Okay, sir. Thank you for the answer, the Dava. I think accept the answer. So the next is the question from the David Muhammad Koroma. So David Muhammad Koroma, please.
Yes, thank you, sir, for sharing with us knowledge. First, I think you're sharing your WhatsApp. Maybe you need to close it.
Again?
Hello?
Yeah, go ahead.
Yes, sir. I said, I think you're sharing your WhatsApp. Maybe you need to close it.
Oh, hold on.
Okay.
Okay, sorry.
Yes. So my question is, I would like to know how reliable or accurate AI tools in detecting mental health problem compared to the assessments done by doctor, especially in early stages.
Okay, let me put it this way. Even the assessment by the doctors, they normally have what do you call it? A list of assessment. Okay, if these are the situation, this is what it is. If these are the situation, this is what it is. That's what the psychiatrists or the psychologists will do. Okay, or the counselors. Okay. What we are doing is we are getting those information from them. In addition to that, we are helping them by looking at the brainwave patterns. And from the brainwave patterns, we know there are published work as far as the brainwave patterns, what correlate to what. Okay. And with the data collected, okay, we can now get more information. As you know, that's how AI works anyway. Correct? So with the data collected, with the feedback from the psychologists, feedback from the psychiatrists, feedback from counselors, and also the data that we have collected right now, we have a more solid information to determine the kind of issues, okay, and problem where we have with the mental health. You understand what I'm trying to say?
Yes, sir. Yes, sir.
Yeah. So therefore, in this case here, we are doing nothing but to increase the confidence level. Okay, to increase the confidence level, so that by doing all this, we now have a more insight information. Okay, but unfortunately, it is more dependent on the group of people, which is fair. I think that's fair. I cannot generalize by having information to go worldwide to say that, oh, this is the generalized information, and we said, oh, we are super duper good because we can generalize the whole world. We cannot. Okay, human in different world has different situation, have different experience, different exposure, and because of that, the situation is different. I give you an example. When I use the word please, it means a different connotation with a different tonation. Correct? Like, please help me. Please help me. So those are already two different things, because one, when I'm a little bit angry, when one, I'm just being calm. Correct? So therefore, and when you go to Japan, for example, so when they actually have experienced emotion, the emotion reflected on the brain are different than the emotion when we do it here in Malaysia or you do it in Indonesia. That is why generalizing, okay, without the IAPS, International Affective Picture Standards, is going to be very wrong, because there is no standards. So that is why we use the IAPS as a standards, and with that standards, we now determine, hey, these are the situation. Okay, these are standard that has been generalized by the psychologists, by the psychiatrists. They have used that standard. So at least we know, hey, these are basically the foundation. Then deriving the basis function will be much easier in this particular context. Does that answer your question?
Thank you, sir.
Okay. Thank you, sir, for the answer to question from the. Okay, next question, sir, from the Raihan Zahwan Saleh. So the Raihan Zahwan Saleh, please.
Assalamualaikum, Prof. Abdul Wahab. So I'm gonna ask for there is some question, but I just asking that my first question only. So in this trend, like digital biomarkers and precision psychiatry, the medical field is moving like precision medicine, treating patients based like on their specific biological data rather and that one size fits all approach. So, my question, Prof. There is a global shift towards precision psychiatry, like using predictive EEG biomarkers to determine which specific medication should, like a patient's brain psychology. Is there any technology that currently being developed at IIUM, or just a prototype, or there is just idea that in this direction? That's my question, Prof.
Yeah, I think you know and I know. Human is not that straightforward. You have certain sickness, and I tell you that this particular medication is a superb medication, You take it and it can cure you. Okay. And sometimes as human, these are just placebo effect. Correct? And with placebo effect, it can really cure you. Because of why? Because of the human emotions, you see. Allah, actually built us in such a way, that the belief becomes very, very strong. And when this belief become very, very strong, a lot of things that we do can actually happen. See, even if you have a very good, strong medicine, that it may not cure because you have so negative emotion that contradicts to whatever that particular medication want to play the role. That is why, to me, in my study, we found that emotion plays a very important role, even though what kind of medication you give. That is why whenever we do like neurofeedback and so forth, the training, this brain training, you must be, first of all, know about your brain itself. We educate you. We tell you, hey, these are the situation, these are what it is, and you have to really understand how your brain actually works. Then you actually train yourself as far as the brain, okay, and you know how to train my own brain, okay, in this particular context. So we are assisting these people, so therefore, like for example, the psychologists have their own way, their own set. The psychiatrists have their own set of things, that they want to do as far as the diagnosis and the therapy. Okay. So by doing something like that, we are helping them, by ensuring that these individuals are aligning themselves to whatever therapy that they're doing. By aligning, we are trying to aid the recovery. You see, we are trying to aid the recovery, and that's the whole function. I give you an example. We do have patient in Europe, for example. We work together with our friend in the Netherlands and the European group. They have around 200 over centers, that does this neurofeedback and so forth. Actually, what it is, basically, we do it for stroke patient. And in stroke patient, one of the things that become critical is monitoring. Monitoring individual, whether they are doing the therapy or not. Not just the brain therapy, but also the physical therapy. So in this particular case, by ensuring, they build up the confidence. Hey, I want to do it. I really want to get there. So by doing something like that, it expedite the whole process. You see? So therefore, in this case here, a combination of the medication, okay, and also the physical physiotherapy, and also the mental, in this case here, the brain training, okay, the whole thing is the approach that we are doing right now. I'm not sure about having one medication, one devices, or one concept to fit everything and cure everything. I think that is going to be superficial to me. Okay, I may be wrong.
Okay, thank you for your answer. So, I think that your answer is there is no technology that fit 1%. I mean, one data fit all person. That conclusion.
It has to be like, for example, like I mentioned earlier, the EEG that we have right now, we analyze the data based on the group okay, that we have here. Okay, the brain functionality for different places may be different, so we have to analyze them separately. That is why profiling becomes very important and critical. Gamification becomes important and critical in this case here, because human at a different exposure and so forth behave differently. Okay, the focus is very different, so therefore we have to really cater for all that. So even Allah says in the Quran, you know, that most important is the individual. There is always areas, you know, for you to improve. Okay, so it's never fixed that, hey, this is what it is for you. No. There is always you know, apa ni, hukum-hukum yang membawa kepada apa dipanggil ni? Oh, I just missed it. Khilafiyah. Kita ada khilafiyah. Kenapa ada khilafiyah? Macam itulah kan. So therefore, it is important for us to note on that. Okay. Yes, Rehan. What do you think?
Yes, sir.
So is that basically the answer I've given you?
Sorry. So that basically you said khilafiyah last sentence.
Yeah. So what I'm trying to bring to you is that there is no such thing as one device to cure everything or one.
Oh, I see.
That's what I'm
Okay.
trying to say.
Thank you very much. Thank you
Yes,
very
yes.
much for the answer.
Thank you.
Okay, thank you, sir, for the answer the question from the Rahan Zawan Saleh. Next participant, if you want to ask the question, you can using the raise hand or the writing question in the chat box with the format name of the questions. Okay, sir. I have the question from the Ratandi Hamad Fauzan. So the Ratandi Hamad Fauzan, please.
Okay, thank you. I have a question about social impact and culture about mental health technology. So my question is, the first is, how can mental health technology be adapted to the cultural context and local values of Asian societies? And the second question is, do mental health technologies generally help reduce the stigma surrounding mental health disorder, or do the risk creating new form of stigma? Thank you.
Yeah. I think one issue is that we have, especially with the younger generation, you know, is that whenever you say that, oh, you have some mental health issue, so it becomes stigma. Stigma. Now that everybody, you know, is, oh, you're in trouble, you know, you're gonna have mental health and so forth. That is why one of the things that we're trying to do right now is that, for example, like you, master students, and when you graduate, you know, you should think about how to actually do it subtly. Example, like games. We develop games, and in that games, whatever that you answer, like question and answer games, you know, then that brings to a point where we can identify. We can identify whether this guy, you know, is under stress, is under anxiety, you know, or is suicidal cases, you know. So we can identify those. For example, if you can integrate some of these games that you develop, okay, together with other bigger games, okay, that your whoever the gamer is, especially kids, in the secondary school, they will have to go into play your games first before they go and play the actual games. You know, you can develop this. We have our own Games My Lab, in our own Games My Lab down at the Kuliah of ICT. We encourage students to play games. No need to go outside. You know, you can play games here. You know that, because the whole idea is that we want to control. We want to be able to monitor these students, their performance, and so forth. So if you can have something like that, don't you think it is far better off rather than to restrict them and say, no games. Yeah, you want to play games, fine, but play this kind of games, you know. and then you educate them at the same time, because you want to make them more resilient. And we found what is important is that in order for them to be more resilient, you have to strengthen the frontal area. I did not show you about the findings that we have in order to find whether student with porn addiction, most of these students, almost 90% of the student with porn addiction, the frontal area, the brain is not active at all. Not active. That means they are they are not resilient at all, towards this addiction. So you have to train them to be resilient. How do you train them to be resilient? Look at the frontal area, get them to do more so that the blood will flow into the frontal area. The frontal area will be used to think rather than just to follow in that kind of manner. So you increase the executive function. How do we increase the executive function? My recommendation for you, especially master students who are doing mental health, you have psychology. You take subjects from psychology to help you identify some of these issues, so that you are far better off, with your masters, and you have a psychology as your free electives. Ada tak free electives in your program? I do not know. Yeah, maybe that is a better way to do it. So that's my recommendation to you, is that, how to train to be resilient. Look at the frontal area. There are a lot of work that people has done, and looking at the frontal area itself, and there are a lot of instruments, devices that just look at the EEG for the frontal. One of them is Muse, M-U-S-E. If you Google, you can take them. The other one is Neuro, N-E-E-U-R-O. Okay, those are the two devices that I know who produce very good detection of EEG at the frontal area. And it can be very, very useful. Frontal area is the executive function. Professor Jamal Badri, he's a psychologist, very good psychologist, Muslim. And he says that, in order for us to train our individual, to be more resilient, get them to do more sujud. Why? Because by doing more sujud, you are allowing the blood to flow into that particular area, and you allow that particular frontal area function to be more active. See? So that is why there are a lot of correlation. When you study, you correlate everything that you learn, you study with respect to the Quran and Sunnah. I think there are a lot of things that you can benefit from it, inshallah. Does that answer your question, Ratandi?
Yes, thank you, sir, for the answer my questions. Thank you.
Okay, maybe next participant, if you want to ask the questions. Okay, next the question from the Rizky Asibuan. For the Rizky Asibuan, please.
Yes. Maybe I have a question for me. Just curious about, do you think can wearable device help us to monitor stress or sleep disruption that caused by excessive screen of use?
Yes, there are a lot of published work already done. If you refer and you try to Google some of this published work, a lot of these devices, for example, like you have the watch, even some watch, they have all the detail, except the apps may not be fully available. And then, like I mentioned, the Neuro device, or the Muse device, they have actually used it, and there are some researchers who have actually use it, to measure stress and also anxieties, in doing something like that. But it cannot be just one one shoes to fit all, one size to fit all, cannot. So there must be a combination, So therefore, these combinations are important and critical. What is your stimulant? The stimulant that you give to do the measurement of the brain wave becomes important and critical. So therefore, you must study. That is why I said the importance of the psychology. the psychological study in this case here, if you have a better knowledge on psychology, then you know exactly what kind of stimulant that I want to give, okay, for me to do this kind of study. But be careful, in some countries, okay, whatever stimulant that you give to this individual, you need to get approval from the Ministry of Health, okay, or else you'll be in trouble, you know. But if you do it under brain training, you're okay, because in brain training you are actually training the brain. It's just like doing mathematical, you do a lot of mathematical sum, because I want to do brain training. I want to train my brain so that now the brain can do better as far as mathematics or arithmetic is concerned. You can do something like that on that particular reason. But if you want to do it for medical purposes, they will object to it. They will say no. That is why we do not use, we don't diagnose. I cannot diagnose because I'm not a medical doctor. I work together with my hospital, SASMEC in Kuantan. Okay, they can do the diagnosis. They can give medication, but I cannot. I'm just assisting them. I'm giving them all this opportunity, for them to expand their horizon and understand the human behavior. I think that's the difference between telling yourself that, oh, I'm going to do diagnosis. No, you cannot. You're not a medical doctor to do diagnosis, but you can assist. You can help the medical doctor. But if I do brain training, I'm okay. Then that means I'm training my brain as though that I'm, getting the individual to do more complex maths. I train them. So therefore, in this case here, they are training their own brain in order to be resilient. I think that's the thing that we wanted to do. Right, Ricky?
Yep. Okay. Thanks, sir.
Okay, thank you. Question, are there question from the Ricky Sibuan? So the next question maybe for the participant. Any question from the participant? Okay.
Okay, Prof. Thank you so much, Prof, for your time. Sorry nih, I just finished my meeting right now. Actually, it's really great honor to having you here. Prof, even though I just finished meeting, but I hear really valuable insight from you. But I'm thinking regarding the correlation that mostly in your research, First, I'm thinking regarding the issue of causation, because correlation may show us, that depression, let's say, is associated with social media use, but it's not necessary. Social media cause depression. So how we can avoid misinterpreting correlation as causation in this issue? Another issue that may I raise up regarding the latent or indirect variable that mostly we use in mental health, when we do survey, let's say. Let's say like depression, anxiety, stress. Those are the construct that are not directly observable. But in this case, we try to measure through self-report questionnaire. So as a result, maybe those correlation reflect the artifact in regard the measurement. But let's say like cultural or linguistic can create bias that in certain case affect the response. This the other thing that I want to ask you. The last one maybe regarding the co-founding. I'm thinking in this case, the mental health data somehow is really highly vulnerable to confounding variables. Let's say like socio-economic status, or childhood trauma, or maybe sleep quality, or maybe physical illness, and many others. So if those co-founders are not controlled, those correlation coefficient, I guess, can be spurious. So the relationship may disappear or reverse after adjustment in certain case. I also remember, I also when I'm doing the self-report, for my psychotest, Even at that time, the psychiatrist asked me to do again, yeah, because they what we call it, they see there are indication that I tried to lie at that time. So
Yeah.
this thing that I want to ask regarding the data that we try to observe or we try to collect, yeah, in regard to the mental health. Thank you, Prof.
Yeah, I think to me, very very fundamental fact is we are dealing with human. So because we are dealing with human, you cannot avoid the fact that human has emotion. And what are these emotion? This emotion becomes important and critical unless you can control them. Now, especially as Muslims, Allah already tell us that our emotions is playing an important role. Kita buat dosa, kemudian disuruh kita bertaubat, kan? Itu sebabnya ada taubat dan pentingnya taubat. Betul. Jadi I think this is important. So therefore, this variation, because of emotion, has very seldom been put into the factor in your study. In most of the study, in fact, people don't put it as the factor. So my suggestion is maybe one of the simplest way to do it is that you use SAM, the self assessment mannequin, to see where your emotions stand when you are doing any kind of questionnaire, survey, whatever it is, or even yourself. When you do a self-reporting, at that point of time, you do the self-assessment mannequin. Once you know that, and then you do whatever self-reporting, and then at the end, you do it again. Now you can see the differences being truthful, okay? Whether you are at what particular state of the valence and arousal when you start, and in the end, what is the state of valence and arousal you are. That differences accounts for if you do your self-reporting today, you do your self-reporting tomorrow, it may differ. Unless otherwise, you have the same kind of emotion that you have today and yesterday. You see? So because we don't factor in, very seldom people really factor in emotion, because that involves a lot more in this particular case being human. Being human. I think that's what it is. That is the difference, is that we are human, and then today our feeling and the way we do the questionnaire is going to be different than tomorrow. That is why in the questionnaire itself, there is always a enhancement. What do you call that? The measure of that questionnaire, the index. Muhammad. You normally have that index, to know whether this particular tools, the psychological instruments, is good or not so good based on that particular index. I cannot remember, but anyway, they have those index. That index determine, because the questionnaire itself, some will basically question whether the question is contradicting or not, and how your emotion feel. Because if it is contradicting and your emotion is affecting it, it will be count into that as display. So the other way that I'm suggesting to you is, hey, if you want to do any kind of question, start with the SAM, and with the SAM, and then you have a better feel in this particular case. How is your feeling at that time when you were doing the questionnaire, especially for long questionnaire, where the questionnaire can take 120 questions or so. Correct? Which none of us has been doing it. Unless otherwise, I will, when you do your questionnaire, I put my headband, and I will continuously monitor your headband and see what kind of emotion you are in as far as the headband. It will tell me, in this particular case, okay, the kind of thought process that I have in mind, which nobody has really done in that particular real-time issues. Maybe it's a good research topic. Right? Does that, did I explain everything there, Muhammad?
Yeah, of course, Prof. I guess the time is running up. Maybe I give one response, yeah. Because I'm thinking regarding the situation, yeah. When we try to collect the data, I guess there are ambiguity, yeah, let's say like temporal ambiguity over there. That many mental health study they rely cross-sectional survey because the data collected at one point of the time, yeah. But the information that really need, yeah, in the mental health, it should be sequence or there are duration over there. With in this case, somehow we try to establish the correlation, but it doesn't make sense. Yeah, I come across with many correlational study, but doesn't make sense. Let's say like they say if we eating ice cream, yeah, it can reduce. Let's say like the numbers of crimes, yeah, in our city. Yeah, the study proven, yeah, for the correlational, but doesn't make sense.
Yeah,
So I'm trying right now how we can let's say avoid those three issue, yeah. Is it really matter if we do like you say, yeah, indexing first, let's say, yeah, to make sure, yeah, to know the status or position of our patient, of our audience, yeah, at that time, so we can let's say like do longitudinal study, yeah. We focus to certain status first rather than we try to generalize. Is it okay, or maybe any other strategy that you think of? Because we just want to make sure, yeah, the data that we go from this issue is really accurate, valid, as well as reliable, I guess. Thank you, Prof.
Yeah, I think Muhammad, you know what it is. We are dealing with human. So therefore, studies when you are dealing with human, when you are doing it now, and then you are doing it later, the results may vary, correct? But you have to take care of that variation, okay? In other words, how do you ignore that variation? Like you say about the ice cream situation, you know? Yes, that could be something that there are some biasness which you do not know. Okay. Chocolates is another good example. A lot of people has done a lot of study on chocolates, you know. But maybe there are more to it than what the results tells you. You understand what I mean? Because we did not see the hidden information. We only look at it from what you see rather than what is hidden, you know. So therefore, there are more to it, you know, in this particular case. Like you said, the variables that the hidden variables, you know, is not shown up, you know. But your question is how to extract those hidden variable, how to make that hidden variable visible, you know, which is going to be a challenge. And no solid research has done something like that today. It will be a real breakthrough if we can do something like that solidly, you know, and basically that, no, this is the way. How to visualize, how to make those hidden variable visible. There must be a hidden variable, correct? Not shown. I mean, it's not that straightforward. Everybody is taking it in the superficial level. And that's our biggest problem. Correct. That is why I go and study the brainwave, not because of anything, because I want to look at your brain, you know, rather than you do the questionnaire. You see, because if I look at the brain itself, then I really know, this is what your thinking is as far as the brain is concerned. But again, brain itself means nothing. So I have to relate brain to emotion. That is why I always use the IAPS, the International Affective Picture Standards. There is a standards that I base on, or else people will question me. What are your standards to tell me that your EEG, what you do the analysis is correct? So that is why I have to have a standard. And that standard is my psychological standards based on the IAPS. We can continue some other time. Oh, I can give a good lecture when I go there to. You are in Jakarta, right? Apa nih? You are in Bandung.
Bandung, Prof.
So maybe one day I go to Bandung and visit you. Maybe we can give a proper lecture and discussion.
Okay,
It'll be
Prof,
quite
thank you. Yeah, because I'm thinking right now, yeah, somehow we try to reduce, yeah, the complex human experience. We try to make it simple, yeah, by the number, and somehow, yeah, there are the thing that really important is not extracted through the study. And at certain point, I also curious, yeah, whether the items it translate well or not, yeah, across the cultures. Because yeah, the regulation we know, yeah, culture also another aspect, yeah,
Yeah.
and those variable, yeah, somehow ignores the situational meaning that really important, yeah, for the mental health, because yeah, so many complex situation that yeah create, yeah, those mental health. Anyway, thank you, Prof. Yeah, it's really nice to having you here. Yeah, hear your insight. Thank you so much.
Okay, inshallah, we'll meet again.
Inshallah, Prof.
Okay, ladies and gentlemen, the session Q&A is the finish. So, ladies and gentlemen, we read the end of the Professor Isaac volume 19. We like the thank you very much to the Professor Dr. Abdul Wahab Abdul Rahman for the sharing is the valuable knowledge and insight. Thank you so much to all the participants for joining the session. And I'm sorry for my mistake. We hope today the discussion is useful and give a new understanding about the role of the technology in the mental health. Wassalamualaikum warahmatullahi wabarakatuh. Thank you and I see you the next Professor Research session.
Inshallah. Assalamualaikum.
Terima kasih, Sir.
Terima kasih. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.